Hi, I'm Dr. Amy Banulis, a board-certified OB/GYN physician practicing with Kaiser Permanente in Northern Virginia. Today, I'm joined by my incredible colleagues who are all minimally invasive gynecologic surgeons, also practicing at Kaiser Permanente, Dr. Blosser, Dr. Small-Lane, and Dr. Trailer. We are very excited to be talking to you today all about uterine fibroids, what they are, how they're diagnosed, when to see a doctor, and what the treatment options are. Fibroids affect more than 50% of women, and while they're oftentimes asymptomatic, they can cause significant symptoms for some women, such as pain and heavy bleeding. So I'm here today with my colleagues to walk you through all that information, help you decide what treatment options are the best for you. So before we get started, I'd like to have our panelists introduce themselves, and I'll start with Dr. Blosser.
Hi, everyone. I'm Dr. Stella Blosser, and I'm a board-certified OB/GYN. I'm also a specialist in minimally invasive GYN surgery, and I'm so happy to be here to talk about this really important topic.
Thank you. Next, we'll go to Dr. Small-Lane.
Hi, good afternoon. I am Dr. Small-Lane. I practice at the Largo location. I am a board-certified OB/GYN, and I am fellowship trained in minimally invasive gynecologic surgery. I have a particular passion in helping women dealing with fibroids.
Great, thank you. And next, we have Dr. Trailer.
Good afternoon. I'm Dr. Jessica Trailer. I am also a board-certified OB/GYN and also fellowship trained in minimally invasive gynecologic surgery. I practice in the DC suburban Maryland service area and specifically at the Silver Spring Center. I'm happy to be here.
Great, thank you all so much. And so we're looking forward to any questions. For those of you who are watching us live, please post your questions in the comments on Facebook. All right, so let's start with some basics. Dr. Blosser, can you just give us the basic information about what fibroids are?
Yeah, so fibroids are super common. Let's just start with that. Many women will be diagnosed with fibroids in their lifetime. And it's actually estimated that even around 70% of women have fibroids. Some might not even know what they are. But they're benign smooth muscle tumors of the uterus. It's one of the most common tumors that women will have in the reproductive organs. And there is a, if somebody wants to pull up a diagram, there's many different types of fibroids. So depending on the type and location, the types of symptoms that a person might have could vary big time. So if someone has a really large fibroid at the top of their uterus on the outside, like this pedunculated one, they might have bulk symptoms, pressure, but somebody who has fibroids on the inside, like this one in the cavity here inside the uterus, like you see this one here in the middle called the submucous fibroid, that one, that can cause really heavy periods. So during this time, I hope we'll get to talk about the different types of fibroids, different symptoms of fibroids, but I feel like this picture kind of helps to clarify, but they're benign smooth muscle tumors of the uterus, very, very common.
Great, thank you, Dr. Blosser. You did mention the word benign. I think a lot of women get concerned about whether these can be cancerous.
That's right. So that's the good news is they are by definition benign. And I think a really important thing to bring up is that they're not thought to be precancers where if you don't do anything, maybe one day they'll turn into a cancer. Of course, it is possible a person could have fibroids and they could also have cancer, but it's thought that you had cancer that came independently of the fibroid. It wasn't that the fibroid turned into cancer. So they are benign.
Great, thank you. And Dr. Trailer, can you tell us a little bit more about what the risk factors are, who is more likely to have fibroids, do they run in families, et cetera?
Absolutely. As Dr. Blosser mentioned, fibroids are incredibly common with that 70 to 80% of women will likely experience them in their lifetime. There are certain groups that seem to be more predisposed to fibroids. For example, fibroids seem to be more common amongst Black women. And not only do they seem to be more common, but Black women tend to present with fibroids earlier in their lifetimes and often with more clinically significant symptoms, meaning symptoms that are bothersome enough to warrant treatment or some sort of intervention to help make those symptoms better. And you mentioned, families, that it does seem that in some studies, there could be some association with genetics or familial distribution of fibroids. You may see this, I see this oftentimes with my patients when I counsel them about their fibroids, and they tell me that either their mother or their sister or cousin also experienced fibroids.
Great, thank you. And what about age range? Are there any ages where they seem to be more or less common?
So in my practice, I actually see many patients who present sort of in their 40s with fibroid symptoms, but I've had patients as young as their 20s and as old as their 70s or 80s. So I really do see patients experience fibroids and often have symptoms from their fibroids across the lifespan, even though we seem to notice that they are less likely to present once a patient enters menopause. That doesn't mean that the fibroids go away once someone enters menopause, but sometimes less likely to present with new symptoms at that time.
Great, thank you. You mentioned a little bit about symptoms, so I'm going to turn to Dr. Small-Lane to tell us a little bit more about what symptoms women may experience.
Yeah, so fibroids tend to cause heavy bleeding and painful periods. That's kind of the hallmark of fibroid symptoms. So that could be bleeding for extra days or having to change extra pads or tampons each day. But some women will also have bleeding between their periods or other types of symptoms. So they can have a difficulty emptying their bladder or having to pee often, wake up at nighttime to pee because of bulk symptoms from large fibroids. Some women will even have bowel symptoms, so problems having bowel movements or constipation. But interestingly, most women with fibroids don't have any symptoms at all and have no idea that they have a fibroid. So a woman could have a fibroid and a whole lot of symptoms, or a woman can have even many fibroids and no symptoms at all.
Great, thank you. And what about size range?
So
How does that impact symptoms?
Size impact with symptoms. So again, some women can have a large fibroid and not have heavy bleeding or not have painful periods. Sometimes that's based on where the fibroid is located in her uterus. So that picture that Dr. Blosser was pointing out. Other people have a smaller fibroid, but it's in an unlucky location, which can cause a lot of symptoms. But bigger fibroids tend to cause more of the bulk symptoms because they're taking up so much space in the belly, and they could be pressing on like a bladder or bowel.
Great, thank you.
I
So
did also want to say there are some people, they don't know that they have fibroids, but the way they get diagnosed with fibroids is actually because they're undergoing fertility treatment. Like maybe they've been trying for pregnancy and they haven't been successful, so they get the ultrasound done and they get some new piece of information. So sometimes the location can also impact fertility.
yeah, absolutely. And Dr. Blosser, how do most women get diagnosed?
Well, it's usually both combination of things, right? So sometimes it is like, the example I just talked about, they were getting a workup for something else like infertility, and then they got the ultrasound as part of the workup. So they got diagnosed by that. Sometimes though, it's because on exam, they went to their gynecologist and their astute gynecologist was asking the right questions, and they did an exam and they noticed that the uterus felt like it was enlarged. And it is something that you can feel. If they are large enough, you can feel them on exam, and that might prompt the OB-GYN to order an ultrasound to confirm the size, the location. But sometimes it's based on symptoms. So, say you go and you say, well, okay, well, I've noticed that my periods are heavier over the last year or so, and that might be part of the evaluation is doing the exam and ordering an ultrasound.
And so you mentioned ultrasound. What are the best imaging tests or other tests that should be done for women who are suspected to have fibroids?
I usually start with ultrasound just because it's quick, it's easy, there's no radiation involved, it's readily accessible. But if someone is going to be doing what we call it fibroid mapping, where we really want to get down to the nitty-gritty and know exactly the size, the number, the location, there's other imaging modalities that might be even more accurate. So regular ultrasound doesn't involve putting anything inside the lining of the uterus, but there are special types of ultrasounds where we put a little water inside, and it really helps to show to what extent, if any, the fibroids go into the cavity. And then MRI is probably the best of really mapping out the fibroids and in terms of the number and location, because if you have a very large fibroid, sometimes on ultrasound, it's hard to see the smaller fibroids that are right next to that big one. So the MRI, in my opinion, is probably the best one. What do you guys think?
I definitely agree. I find MRI incredibly helpful. As you said, Dr. Blosser, to map fibroids, and it really helps to plan out surgical approach, which we'll probably discuss soon in terms of the different ways that we can target fibroids for removal if a patient decides to have that procedure done.
I agree 100%. So starting with an ultrasound, and then if planning on doing some type of surgery, especially fibroid removal surgery, then an MRI is very helpful.
Great, thank you. And so how does a woman even decide if her fibroids need to be treated? Is there any problem with not treating them, especially if someone's not having significant symptoms?
That's a really good point. Oftentimes, fibroid treatment is really directed by a patient's goals and their symptoms. And so as gynecologists, we oftentimes talk to patients about their overall goals, any symptoms that may be bothersome. And specifically, we also talk about their reproductive health goals, if that's a concern, because some of the treatments that we offer for fibroids are not necessarily recommended for those who desire future pregnancy. And so it really comes down to that discussion between the patient and their gynecologist to kind of outline what makes the most sense for them.
Yeah, absolutely. And what about, and we always hear about, and we'll talk a lot about surgery, but are there any non-surgical options for women to consider? Dr. Small-Lane, do you want to take that one on?
Absolutely. There are a lot of non-surgical options. There's a lot of different medications that can be used to help with fibroid symptoms. Unfortunately, we don't have a medication that makes fibroids go away. I wish we had that kind of medication, but we have options to help with things like heavy bleeding and painful periods. And some of those medications are hormonal. Some medications are not hormonal. There are even ones that are FDA approved or FDA indicated specifically for women who have fibroids and fibroid related symptoms. And with these medications, a lot of women will never need surgery, or they can use it to control their symptoms to have a better quality of life leading up to a surgery.
Great. And then
Dr.
what
Lewis,
about
I love
other-
that you asked the question, because I feel like it's definitely not one size fits all. And I feel like one thing is, because you had said, what do you do when your symptoms aren't really bothering you that much? So at what point do you need to intervene? And I have seen some cases though where they were kind of like, it didn't bother me that much, but by the time they decided to move forward, the fibroid was the size of a bowling ball. And I do feel like sometimes there's a little bit of a balance, right? You have to kind of consider, what are my goals ultimately in the big picture? So I feel like for me, I like to sit down with a patient and say, okay, I want to understand your situation because it's not one size fits all. What are your short-term goals and what are your long-term goals? Because for the person who's young, who wants to get pregnant one day, even if it's not really bothering her that much, if somebody has a fibroid the size of a bowling ball and they're young, knowing that fibroids will grow, basically through menopause, I would probably recommend intervention, even if she's saying it doesn't bother me that much. because I also feel like sometimes people get used to their symptoms, like, oh, that back pain that I've been having for years, I didn't realize it was the fibroid. So sometimes you do have to do a little bit of deeper digging and really kind of figure out, are you really not having symptoms? Because sometimes they fibroids can be really, really large. So I would definitely encourage people really to just talk it through with their doctor and say, these are all my concerns. What do you think? Knowing that, if their goal is fertility, ultimately, maybe if they, especially if they want a minimally invasive approach, maybe doing something sooner rather than later is better.
That's a really good point, Dr. Blosser, because I still have patients that are surprised when we do the exam and I point out to them that the fibroid is causing some of the enlargement or the bulkiness to their abdomen. And it's possible they've just adapted over time because it is part of them. But oftentimes patients can be really surprised when we really kind of hone in on how large the fibroids have grown.
Yeah.
Do you recommend surveillance for fibroids? So if a woman comes in and she's not having that many symptoms and has maybe like a medium-sized fibroid, do you recommend that she has a repeat ultrasound in like 1 or 2 or 3 years to check to, make sure that it's not getting larger or not getting to a point where a minimally invasive option isn't there anymore?
Yeah,
For me, it's a
Yeah.
really good question. I think it's something that people encounter all the time, right? For me, I don't do it as a routine, like just like an annual ultrasound, but I do want to see, if I know someone has fibroids, I do check in each time they come for a check. Okay, so are you having symptoms at this point? And we do the exam. If on exam, their uterus doesn't feel particularly large and they're not having symptoms like heavier periods or those things, I'm not necessarily going to be intervening. So sometimes if you do too much imaging, it's almost like, what do you do with that information? But I definitely feel like, depending on what their goals are and what their symptoms are, maybe just checking in once in a while, at least, in person to check in to see if there are changes. And I have a pretty low threshold for getting that follow-up ultrasound.
Sure. Yeah. And I think what makes it difficult is there's not a predictable rate of growth of fibroids.
Yeah.
We can't say, okay, fibroids on average grow X number of centimeters per year, right? So I think that kind of makes the planning a little bit tricky. I think the way I tend to approach it with patients is if they're asymptomatic, we wait and see how they're feeling. And if they develop symptoms, then repeat the imaging. But I agree. I take the same approach of not necessarily saying, yep, you need a ultrasound every 6 months, no matter what. I think it's really, so much of this really depends on a woman's symptoms.
You bring up a really good point, Dr. Benulis, about not being able to pinpoint when or how fast someone's fibroids may grow. And then also this question also comes up in patient discussions about when or if fibroids will regrow if they've already had an intervention or a surgery, which of course we do discuss in those visits because fibroids can return and regrow in the future.
Right. And yeah, before we dive into surgery, one more option that's not necessarily surgical, but it is a procedure, uterine artery embolization or uterine fibroid embolization. Would anyone like to describe a little bit about who might be a good candidate for that and what's involved?
Sure. So a uterine artery or uterine fibroid embolization is a procedure that is done with our colleagues in interventional radiology. And this is where they go into the blood vessels that feed your uterus, feed the fibroids, and block them. And by blocking the blood supply, it causes fibroids and uteruses to shrink. Again, it's not going to make fibroids go away completely, but they can get smaller and help with bulk symptoms. A lot of women have relief from heavy bleeding. Even if their periods continue, it's just more manageable and less painful. One of the challenges with the uterine fibroid embolization is that our bodies can kind of outgrow it. Our bodies are smart. So it senses that an organ's not getting enough blood supply and starts to make new blood vessels, but that happens slowly. So kind of over like a 5 to 7 year period. So kind of the sweet spot possibly to have a uterine fibroid embolization would be when you're maybe 5 to 7 years out of menopause. And that's hard to know because we never know for sure when we're going to go through menopause. But for women that are done with childbearing and probably over age 40 might get the most benefit, not that it isn't available to women that are younger.
Great, thank you. All right,
think
so
the
now
other
let's
thing to
talk
bring
about
up-
what you are all experts in, and that is surgery. And I'm sorry, Dr. Blosser, did you want to add one more comment to the?
No, just one small thing is, because I think this is something that I get asked a lot, is about, are you a candidate for a fibroid embolization if you want to get pregnant? I feel like that's a common question that I get, because some women, they're not looking to have surgery, but they are looking for a less invasive approach, and it's a great option. But the fertility issue, and I don't know, it's generally speaking, for me, if I know somebody is interested in fertility, I don't recommend fibroid embolization, because there are studies, many case reports of women who've gone through it and who've gotten pregnant. But because we don't have large scale long-term data, generally speaking, I don't usually recommend it if fertility is a goal.
Yeah, that's a great call out. Thank you. All right. So moving on to surgery, we'll start with you, Dr. Traylor, and I'll give everyone a chance to talk a little bit about the different types of surgery that we can offer to help women with symptomatic fibroids.
Absolutely. So for women that do choose to have surgery for their fibroids, there are a variety of options and approaches that we can use to remove those fibroids. So just thinking about broad strokes, if someone can pull up that diagram of the uterus and fibroids again, a lot of what determines which surgery is most appropriate for any individual patient is fibroid location. So location is incredibly important. If you look at the diagram, for example, the fibroid or submucous fibroid that's within the uterine cavity, that's something that can be approached by a form of surgery called hysteroscopy, which means we're placing a camera and fluid inside of the uterus to do the surgery to remove the fibroid, or the myomectomy. Other fibroids that are located either within the wall of the uterus or on the surface of the uterus can be removed by other approaches, but not the hysteroscopic approach. One of the benefits of hysteroscopic surgery is that it truly is incisionless, because the approach is vaginal into the cervix and into the uterus. And so this is often same-day surgery with very little downtime, and patients tend to recover very well. I'm sure my colleagues can touch upon some of the other approaches that we use for myomectomy.
So another approach is going to be through the abdomen. So this is not incisionless, but we do have different ways of doing it. So either laparoscopic with small incisions on the belly, or larger size incisions, depending on the number and size of fibroids. And that would be to remove the ones that are within the wall of the uterus, so the intramural fibroids, or the ones that are kind of pushing towards the outside part of the uterus, like the subserosal or the pedunculated fibroids that are on the outside. And when we're talking about options for removing fibroids through the abdomen, we have the laparoscopic, with or without using a robot for assistance. And then we have mini laparotomy techniques where we use bigger incisions, but still teeny tiny, where patients are able to go home the same day. And then we have larger incisions, which could be more similar to like a bikini cut, which is often seen during a C-section, or sometimes an incision that goes up and down on the abdomen. And it's really individualized by the patient's history, as well as her fibroid size and location, as to which option would be the best. And we're grateful to have availability for all these different modalities at Kaiser.
Great. And Dr. Blosser, can you tell us a little bit about what women can expect in terms of recovery with the different types of surgeries?
Yeah, and I really love how Dr. Smallane and Dr. Trailer have emphasized it has to be tailored, right? So the recovery, it is going to ultimately depend on what happened. I love hysteroscopic myomectomy when it's feasible because the recovery is so short. No scars, no incisions. So also the recovery is really quick. I mean, people go back to work the following day, literally the next day. Most people just take some Motrin, for cramps, maybe the day of, but most people, it's very, very quick recovery. For fibroid embolization, that also needs recovery time. Most people still take a few weeks off because as the fibroids are degenerating, that does cause some cramping and pain. Then for surgical options, that is really going to depend on how big was the incision, how many fibroids were removed. The person who had 20 fibroids removed from all over their uterus, they might have a bit more cramping than the person who had like one pedunculated fibroid, a very small incision. So it could be anywhere from, I would say, 2 weeks to 6 weeks. Typically 6 weeks is going to be for a bigger incision where we're going to be restricting their ability to lift or to be more active. If everything is very, very small and maybe even 2 weeks out, they'll be back to working. But it also depends a lot on what's the nature of their work. Are they on their feet? Are they doing heavy lifting? And so the person who's very active, I would recommend that they take more time off. Now, a lot of people telework, so they're back a lot sooner. It really does depend though.
Yeah, definitely. Any other comments on surgical approach? I think I would like to spend a little bit of time talking about pregnancy and how fibroids can impact future pregnancies, or what women can expect if they have fibroids and they're pregnant. That's something that we see very, very commonly.
That's a really good point. We do see fibroids very commonly in both our pregnant and non-pregnant patients. I always like to point out to my patients as they are considering their fibroid treatment options that not everybody needs to have an intervention. And we have plenty of patients who do have fibroids and who have gone on to have successful pregnancies and deliveries. We do know that some patients who do have fibroids and become pregnant may be at higher risk for certain complications. And unfortunately, we don't have a great way to pinpoint exactly who those patients will be who may be at higher risk for those complications. But in general, it seems as though patients with fibroids that are sitting right in the middle of the uterine cavity, or that have those submucous fibroids, or those that have really large fibroids, seem to be those that may be at higher risk for certain complications that can occur in pregnancy with fibroids.
And so if a patient has a fibroid that needs to be removed prior to pregnancy, how long should they wait to get pregnant after their surgical procedure?
I usually recommend patients wait about 4 months after fibroid surgery before becoming pregnant.
Great. And
Also,
how
it depends on the type of fibroid removal. So someone that had like the hysteroscopic myomectomy without incisions would be able to become pregnant a lot sooner. But women who've had fibroids removed from their abdomen, it will be longer. And we usually recommend, like what Dr. Trailer was saying, at least 4 months, sometimes 6 months.
Also, the other consideration is just sort of pregnancy considerations after myomectomy. If the myomectomy was the type where we really had to incise into the full wall of the muscle, it is recommended that woman, when she gets pregnant in the future, she shouldn't labor. We recommend a scheduled C-section for women who've had extensive myomectomies, especially where it was a full, all the way through the uterine wall, transmural incision. If it was a, external one, pedunculated, that doesn't apply. Hysteroscopic, totally, she can labor. But when you're cutting through the muscle, there is a chance for some weakness there. And there's something that can happen called uterine rupture. And that, if it were to happen, it could be very dangerous. So we recommend scheduled cesarean deliveries for women who have had that type of myomectomy.
You've raised a good point, Dr. Blasser. I've had patients who've had, 1 or 2 pregnancies and successful deliveries with fibroids, and then come to me for a consultation for fibroid removal. And then part of the discussion is, whether or not the fibroid should be removed now, because knowing that removing that fibroid would mean that the next delivery would have to be a C-section versus removing it after she's done with childbearing. So I've had patients after counseling go on and have their 3rd child and then have a vaginal delivery and then seek treatment for fibroids. So very individual treatment.
Definitely. Another common question I get from patients is, well, I know I have fibroids and I'm thinking about having or have another reason to have a C-section, or why can't I just have my fibroid removed and my C-section at the same time? Which is a really good question. However, during pregnancy and at the time of delivery, there's a large amount of blood flow going to the uterus. And so generally we try to avoid additional surgical procedures at the time of delivery or C-section because of the risk of higher amounts of blood loss.
Yeah, that's a great point. And what about fertility? A lot of women worry about whether fibroids could cause infertility.
There's actually a lot of research on this because not all fibroids affect fertility. Fibroids that are on the outside and they're not pushing in any way on the cavity and they're not obstructing a tube, that's actually not shown to affect fertility. The only ones that have really definitively been shown to potentially affect fertility are the ones that push on the lining. Because the lining of the uterus, those were in embryo implants. So if there's anything there, it could potentially impact. Some fibroids that are, especially if they're greater than 4 centimeters, and if they are close to the lining, those could potentially affect fertility. Other than that, though, there's not a lot of good evidence that the other types of fibroids affect fertility. So like what everyone else was saying, just because you have fibroids doesn't mean that you necessarily have to have treatment prior, to trying for pregnancy.
Yeah, absolutely. And I think the good news is that the types that are most likely to cause infertility, those ones in the cavity or submucous, are also the easiest ones to remove with the quickest recovery because we can do those hysteroscopically. So there's not as much of a delay in terms of trying to conceive. All right. Well, I am so appreciative to all of you for sharing your wealth of knowledge on fibroids. I want to give each of you an opportunity, just to share any closing thoughts before we finish up today. So I'll start with you, Dr. Smallane.
Right. Yes. Thank you for including me in this conversation. Fibroids are a passion of mine. And I think one of the biggest takeaways from our conversation is knowing that fibroids are common. And if you have symptoms that seem like they could be fibroids, to seek care with your OB-GYN, because there are different treatments available. And these treatments can really improve your quality of life.
Great, thank you. And Dr. Blasser.
I completely agree with what Dr. Smallane took the words right out of my mouth. Definitely seek care. And the other thing I would also say is if you've been told that maybe abdominal myomectomy is your only option, also as the 3 of us, we do specialize in minimally invasive surgery. Also maybe consider getting a second opinion. Sometimes if you ask 10 different board certified specialists, you might get, different recommendations. Everybody has, their own angle on things. So don't be shy about asking for a second opinion. I think one of the wonderful things about Kaiser Permanente is that we do have this integrated system. We are all on the same page. Everyone is here to try to get you to where you want to be and accomplish your goals. So also don't be shy about asking.
Great, thank you. And Dr. Traylor, anything you'd like to add?
Thank you so much for including me as well. I would add that in addition to talking to your physician, talk to your family, talk to your friends. As we've spoken about throughout this, fibroids are so common. So likely a friend or family member has also experienced fibroids, and you may find some great community and support in speaking with others about their experience. But just remember, the same fibroid treatment that your grandmother or aunt may have been offered may not be what we're able to provide today.
Great. Thank you all once again for taking time out of your very busy days to share your knowledge. And thank you to everyone who tuned in to learn more about fibroids. For more health information like this, please log on to kp.org/doctor. And from all of us at Kaiser Permanente, be well.